Hi, it's Vic out with Hellstorm. Today I have Uli Chettipally on. He's an incredible guest, an emergency room physician, and then he has grown up into leadership and got into a lot of AI and technology, published a book about AI, and now has launched his own startup. Really great guest. We talked about a lot of issues. It was fun to do. I think it'll be fun for you to watch. Again, Uli Chettipally on the Hellstorm. Thanks a lot. Welcome everyone to the Hellstorm. Today I have Uli Chettipally here. Really excited, Uli. Thanks for doing this.
Thank you, Vic.
So as we get started, maybe just give the audience a little bit of your background. You've been in medicine for a long time, but then recently kind of moved a little bit. So talk about what you've done.
Sure. Thanks to Vic and Jumpstart Webinars for having me here. My background. Well, I've been a physician, emergency medicine. My first real job was at Kaiser Permanente here in Northern California.
Yeah.
Initially, I was, on the administration track. I was the chairman of the department. Did a few things during that time, and later moved on to research.
And just to interrupt, that started in the 90s, right? So a while, you've been doing emergency medicine for a long time. Yeah.
For a long time, yes. 92 actually.
Okay.
And did a project with Kaiser, helped start a call center in Pasadena. So that I spent another 6-7 years there, and then came back and started a research group within Kaiser. It's called Crest Network. And the research group is unique in the sense that it is within Kaiser. It is composed of emergency medicine physician scientists who are working on problems, solving in the clinical care delivery area. So my role was was the co-founder with another physician. And my main role was I was the technology lead for the group. So what we created there was a platform that sits on top of electronic health record, Epic in this case, and pulls data from patients' EHR, analyzes it from the current emergency department visit, analyzes it, and gives clinical decision support back in real time at the point of care so that they can act on it. So that project became a big success. We won many awards.
Particularly in emergency medicine, the ED docs there's so many different things that get presented that they really do benefit from having the support there.
Exactly. So if you think about, emergency physicians thinking, they are mainly concerned about, is this patient sick or not sick? Mm-hmm. So any kind of help that you can give based on data to the physician is very useful. And it actually decreases the cognitive burden on the physician that is making these decisions very quickly. And so, which also means that, the system has to be really efficient. It has to really take into consideration the workflow, and it has to give, fairly accurate input to the decision making. So that was the challenge that we had. And, and the system I designed and implemented in 21 hospitals and emergency departments. We were able to run clinical trials using these decision support tools. So for example, if there's a patient that comes in with chest pain, the tool will gather the data in the background and some data from the visit and tell the physician, what are the chances of this person having a heart attack in the next 7 days, say, for example. If the system says that this person is a low risk, it's pretty accurate in the sense that the physician does not have to do a whole bunch of testing. observation, admission to the hospital. And so it saves, it saves a lot of work for the physician. For the patient, it is more efficient. And for the system like Kaiser, it is cost effective and also improves the quality of care for the patient. So we were very successful in that program, and we published more than 100 papers, I would say, for now, until now. And there are currently about 14 physician scientists working in that group. So that I would say was the best part of my tenure at Kaiser.
And then you started your own company, InnovatorMD, maybe 2 years ago or a year and a half ago.
Yeah.
So talk about that. That is a platform to really empower physicians. Is that right?
Yeah, InnovatorMD. I started that company right after I got out of Kaiser last year, and the idea is that a lot of innovation that happens from the physicians is not seen or encouraged or given a platform. So our idea was to elevate that innovation so that people can see what physicians are doing, number one, and to be able to support their work, either through networking, education, or even funding. We kind of bring together investors. And so that was the idea. How do we elevate physician innovation? Innovation that you see in the market, whether it's the technology side or the business side, but the real clinical innovation where a person who is in the front line may be able to come up with has a different flavor to it.
Yeah, and then also it's a little bit in a silo, right? So allowing docs to hear from each other and collaborate or share best practices, I think, can result in you have half of it, someone else has the other half, but when you come together, it can be really impactful.
That's true. Networking is a big part of our work. If you think about innovation and research, you can go the biomedical or whether it's medical device or biotechnology, pharma side. But if there's a lot of potential for innovation within the care delivery side, whether it is IT, digital health, or whether it is artificial intelligence, machine learning. I think there is a lot of value there that has not been captured yet, and that physicians are very good at that.
Yeah, I mean they are living the workflow, and they can tell, well, this could be much more effective and efficient for me and for the patient, and cost less if we change it this way. But exactly. Before InnovatorMD, there wasn't a good platform to empower that and get it discussed. And
yeah, our total focus is on physician innovators and physician entrepreneurs, and how do we equip them? How do we elevate their projects and then their work amongst the larger healthcare community? And that's our focus with InnovatorMD.
Yeah. Okay. And so I think I've been doing this show called the Health Storm about a year, a little less than a year, because I saw several trends kind of coming on the horizon pre-COVID pandemic that I thought were going to really be impactful to the system, to the U.S. healthcare system. And I wanted just to learn myself and explore it with guests like you. And so I want to just talk through those 4 drivers. But COVID, I think, has accelerated that. So all of the things that were in place before the pandemic has now sort of been brought to the forefront more. And so the first is sort of your specialty, which is tech enabling better efficiency, better diagnostic, better workflow, more convenience, lower cost in the delivery, in the healthcare delivery platforms.
Yes.
Second is what I call the rise of the consumer, which is consumerism or individuals trying to take control of their own healthcare, control of the decision making, bring more kind of individual power and decision making to bear. But there's not a lot of tools. There's not information. There's not systems to help with that. The third is care moving out of the hospital and into the neighborhood or the suburbs or, in fact, the home. I see that as sort of an ongoing trend. And then the fourth is market entry from non-traditional places, so like Google or Walmart or Apple, that really traditionally have not done healthcare, and they're moving into the space more and more. Talk to me about your view. Do you see these drivers? Are there other ones? Are there ones you think are more or less important?
Yeah. So one of the big things I see as a challenge is the business model of healthcare. When we talk about business model, I'm talking specifically about fee for service.
Yeah.
And I think all of these areas are trying to attack that business model from different areas. For example, consumer focused. That means that if the consumer is able to take care of some of the issues, for example, whether it is home testing, whether it is risk stratification, whether it is avoiding certain things and making their health better, which means that there is less need for the consumer to access the system, because the consumer knows that as soon as they access the system, it is going to be expensive, whether it is co-pays or whether it is other types of expenses that happen. And that is very unique to our business model. When I talk about business model, I'm talking about we are paying healthcare companies and physicians to take care of problems when they arise, which means that they make money when the patient gets sick.
Right.
If you flip the model, which is you make money when the patient is healthy. And so your motivation, your systems, your technology, everything has to flip, which is how do you predict and prevent bad outcomes? In the first system, there's no need to look at outcomes because they're getting paid whether the patient gets better or not, right? If you prescribe,
you do the work and it is executed, then they're paid, no matter whether it has a great outcome or not a great outcome.
Yeah. And so what happens is it drives the providers, whether it is hospitals or physicians or labs, it'll drive them to the activities that make them more money, obviously, right? So if one is making more money, obviously they will want that. If there is a technology, for example, robotic surgery or something compared to regular surgery, if the robotic surgery is making more money or looks good, they'll use that, not necessarily looking at the outcomes. And that's where the problem is. One of the big problems for healthcare in the US is that, the business model of healthcare. Now, all the things that you mentioned, they don't involve that business model. Whether it is consumer-based health, whether it is technology. Now, technology, if you think about technology, mostly making things efficient, predicting things, for example, machine learning and artificial intelligence, predicting and preventing things. That does not make money in a fee-for-service system.
Right.
For example, the minute clinics, they're not necessarily dependent on the insurance system that is, again, built around the fee-for-service system. And so it is all a disruption of that business model that we are looking at right now.
Yeah, and so that makes me think about a topic I wanted to cover with you, which is one of the things we need to do is shift to proactive care, preventative care, keeping people healthy, as opposed to intervening when they are sick and patching them up. I think in the next 5-10 years, the systems need to shift from the effort and the financial incentives, investment, more towards the preventative. But the challenge is, and I want your thoughts on, we still have a lot of people that need acute interventions today. And so is it your belief that we'll have to do both for a period of time? Or how do we transition? How does that transition work?
So I think it is a mind shift that has to happen. Whether it is from the payer side, or whether it's from the insurance side, but the mind shift has to happen, saying that yes, we'll have to continue taking care of the problems that are arising from, years worth of not paying attention to those problems. But it also means that when systems become efficient, there's a chance that a lot of players will decrease their revenues, will decrease their profits, and so there is always this tension between, oh, if you do that, then there is less need for all this stuff that we have already set up.
Right.
And so the incumbents, it's hard for them to switch, because they know that if they do that, they'll have to decrease, what they're spending and what their revenues are, basically. So that is where the biggest challenge is, and that's why you see a lot of outsiders trying to get into healthcare, because they can easily see, oh, what a huge inefficient system. We can make it better by introducing these disruptive notions that, oh, maybe the patient can pay the doctor directly.
Yeah.
Or maybe the patient can take care of themselves.
Well, and of course, I'm a VC, so I'm biased, but I think that can be healthy. Right? Like take One Medical coming in and creating a new approach to primary care is an experiment, right? And I think it could have a really good outcome, but we don't know yet. But over time, these experiments some will work, and then we will slowly adopt more and more of the new things. And in the meantime, the incumbents with lots of ORs and big buildings that they need to keep full, they are running a different kind of primary medicine. And that's okay. That just is the way that our sort of economy, free market economy, with new innovation coming out, it will take little pieces, and then if it really works well, it will become the norm over time.
Yes. So when you talk about primary care, if you think about Medicare spends around 5% for primary care. Mm-hmm. Only 5%. 95% is spent elsewhere. Now, companies like ChenMed and what they're doing is they're taking full risk. In other words, they are taking the full risk of these.
Here's a pile of money, and you have to take care of this person.
Well, yeah, take care of this person for everything and anything that happens to them in healthcare, including hospitalization, surgeries, and all. So what they have shown is that if you invest more in the high touch primary care, you decrease the cost of care, total cost of care, because you're preventing a lot of bad things from happening, patients ending up in the emergency or hospital or surgeries or whatever. If you take care of the diabetes, maybe the peripheral vascular disease in the leg that causes bad problems, gangrene, and eventually amputation could be prevented. Right. So those are the kinds of things.
Bad health outcome for the person, and it's really expensive. And so if you do some preventative, some primary care, some advice, education, you can prevent that, and it's better.
Yeah. Simple things like, making sure that the person is eating the right food. Somebody going and helping with the groceries, so that, this person that is living alone, needs some help. So by providing that, some of these companies have really revolutionized, primary care. I think that's where a lot of that, a lot of the gains that can be obtained are sitting there.
Yeah.
The second piece is the technology. How can you use technology predict. For example, I was doing one project with an insurance company that is developing a diabetes module using AI to be able to predict which diabetes medicine will work for which patient.
Mhm.
If you think technically, if you think about it, it's a fairly simple, well, not simple, but it's doable, right? If there are 65 plus diabetes medicines, and if you're going to do a trial and error method, it's going to take a long time for that person's diabetes to be controlled. And in the meantime, the person's risk of heart attack, stroke, and all these bad outcomes keeps increasing with time.
And it's accumulating too. Like over until you get it controlled, they're having wear and tear and bad things on all their organs, all their body. Yeah.
Exactly. And same thing with high blood pressure. We have all these great guidelines, but I would say only about roughly about half of the patients are actually being treated based on the guidelines. Everybody else, the other half, things are not under control, but technology can be a great resource there to be able to pull that data and show which specific patient, which specific medication, which specific test that needs to be done to be able to control that.
Do you see kind of a tipping point where right now there's a lot of promise, but it hasn't sort of gone mainstream? Is there a point where you see enough accumulation of evidence that everything swings pretty quickly to more this value-based or preventative or holistic? I don't know what buzzword you want to use. They're all similar to me, like sort of shifting the focus to well care versus sick care.
Yeah. Well, predicting the time frame is hard.
Yeah.
Because one would think that, hey, this is a no-brainer. This should have happened a long time ago.
Yeah. Right.
Companies like Kaiser Permanente that have been practicing this for more than 70 years, and but it still didn't happen. I think this is the first time in the healthcare industry history that outsiders are trying to get it. So the disruption will come from outsiders. Whether it is technology companies trying to enter into health insurance market, like Google is trying to do, or coming from the consumer side, like Apple is trying to do, or coming from the retail side, like Walmart, Walgreens, and CVS. They are trying to do.
Or Amazon's coming more through like the suppliers, supply chain at first. Maybe they'll go to the retail, but at first supplier side.
Yeah, exactly. Amazon is coming from there. So all these are coming from different directions, and eventually all these disruptions will add up to something, a big change happening.
Yeah.
Whether it's going to happen in the next
point. The question is when. I mean, it's not easy to predict when that occurs.
Right? I've been saying 5 to 10 years for the last 10 years. So.
Right. Yeah. Okay. Well, Uli, I want to move to your book because I want to make sure we cover that. So you published a book, I guess probably a year ago or so, Punish the Machine, The Promise of Artificial Intelligence in Healthcare. And it's a really interesting book. I want to take a minute and talk to the audience about it. So it lays out a lot of these issues we've been talking about, the challenges of US healthcare, but then shifts to how AI can be used to both decrease the pressure and burnout on physicians, the burden and the workload, and simultaneously increase the results and reduce the cost. So just talk about the book a little bit.
Sure. If you take a look at the whole healthcare ecosystem, there are only two players that are the most important. One is patient, obviously, the consumer, and the other is the physician, or you can say provider side of it. Yeah. So those are the two things that have to be there. At least for
Yeah,
the next
without the
100 years.
patient and the doc, there's no healthcare, right?
Exactly. You can remove, medical devices, you can remove pharma, you can do all those things, say that.
Mhm.
But these two, that's number one.
Yeah.
Number two is that so far the healthcare has been punishing the doctor. And when I say punish in the sense, what it means is that, you are given a unit of work. Okay, so you see 20 patients a day. Let's say your reimbursement is, for illustration purposes, $100 or $10. Let's call it $10. And if you make it $9, what it means is that you have to see more patients. If you make it $8, you have to see more patients. And so the physicians are being punished.
Yeah.
And the
And
way they're
asking them to do more, right? We key in all this data that you didn't have to do before.
exactly. So you have to start collecting data entry, and the sole purpose of that data entry is to bill, right? Again, so if you don't do it, that means you won't get paid.
Yeah.
And so what it does is it's like putting the physician on a treadmill and somebody else is controlling the buttons. Somebody else is making it faster and faster.
Right.
And so what happens is that they keep running faster and faster and they'll fall or burn out or, get fatigued. And we are seeing all those things happening.
Yeah. I mean, you and I both know lots of docs who feel like they got into this calling really to help people, and lots of schooling, lots of work to build your expertise and get good at a practice of medicine. And then we're changing the game on them and increasing the workload, reducing the pay, and they think it's unfair. I think it's unfair. It is unfair.
Yeah. And so that is what I mean by, you should punish the machine, spare the doctor, and save the patient.
Right.
So on the patient side, we're seeing outcomes are really bad. Control of hypertension has actually gone down over time. The deaths from these potentially preventable causes are increasing. And so we haven't made a dent for the patient. And so it is the two most important people are being punished here. And so instead of doing that, what I'm saying is punish the machine. Now, the machine could be the computer. The machine could be, the technology, the artificial intelligence. We are pampering the technology. In other words, if you look at the EHRs, it's so 1980s and so 1990s. We are so, when I was working in some of these great institutions, when I go to my IT department, I say, can you get a report on all the patients who had, let's say heart attacks in the last 1 year? They can't.
Right.
It'll take months before you get that report, right? And so we are actually pampering the machines, pampering the IT. We should be pushing it full throttle, the IT, because it's not, instead of hurting the physician to enter data that is meaningless now because it's just for billing purposes, it's not going to make a big difference in the patient outcome. And so we are punishing the physician, but instead punish the machine. Get a better machine to be able to find clues to how they can help the physician. And that's what I mean by punish the machine.
The machines can take it. I mean, like if tasked with this, I mean, if you go to e-commerce or fintech or travel or any other industry, the machines will take the punishment and they respond very well. They
Exactly.
correctly. Now, Epic and Cerner maybe aren't designed the best, and all the EHRs are not designed to do this. But machines can be designed to do this, and they will thrive. And the doctors then can be empowered and assisted. I mean, I think about an airline pilot. I'm not getting on a plane unless the airline pilot is in the cockpit, right?
Yeah.
But he or she is not doing all the details that they were doing in the 60s and 70s. They are empowered. They're augmented. We have autopilot. We have tools. We have the GPS. And so doctors should be the same. The doctor. So that's one thing I want to ask you about. How do you balance physician judgment with leveraging or like allowing technology to augment that, so they're empowered by it and not kind of stuck with it?
Yeah. And so, the systems that I develop are where the technology is more like a guide to the. Now, for example, when you're driving and the GPS says turn left, and you know that there is a big
accident or something, you don't have
to. Yeah. So you're the person as a driver, you are making that decision. Let's say there's a person that fell on the street and can't get up, and so you can't go over that person. And so that's where we need physicians. That's why we need drivers to be able to avoid, not just blindly follow the GPS, but understand these intricacies that happen all the time. And so I would say for all the I call it scut work, which is just repetitive things.
And there's a lot of medicine that's like that you've done a bunch of times. The decision is very, very likely take this turn. The doctor can approve it, but it's let's empower them. Let's make it easier for them.
Let's make it easier.
Exactly. I use the example of anti-lock brakes a lot. Because I'm a confident driver. I like to drive. I don't want to have a car that doesn't have anti-lock brakes. I mean, I know you could pump the brakes, but I can't pump it as fast as computer systems can pump it. It doesn't mean I'm less of a driver. It doesn't mean the doctor's less of an expert at their practice of medicine. It just means that computers are better at doing certain things than humans are, that are very rote or very need to be done very quickly and don't have need a lot of judgment.
Yeah, and plus, the amount of knowledge that is coming through research and stuff is going up, is skyrocketing.
Yeah.
And so it's impossible for a physician to be able to keep up with that. For example, some of the work that I did at Kaiser is that I can switch on a new guideline or tweak a guideline with just the switch of a button. And suddenly the whole practice within these 21 hospitals changed because I changed that guideline. Of course, only about 70% of the physicians use the system, but that's still great.
Yeah, and that's 30% more than in other systems.
Exactly. And so you can turn on and off several things simultaneously very quickly. Whereas if you have to wait for that knowledge to go in and published, and a physician goes and reads the journal or goes to a conference and learns it, it takes years for that knowledge to go in.
Well, and you probably know the stats. There are hundreds of journals being published every day. So no human can possibly read up on all those. There's not enough hours in the day to do it.
It's impossible. Exactly. And that does not mean that the patient should get inferior care because you can't access the knowledge. The knowledge is there. How do you put it into a system so that it can help the physician make the right decision?
Right. Okay. I want to dive into AI a little bit more because you're really well versed at AI, much more so than I am, and I'm trying to learn about it. So, artificial intelligence has a couple of different levels, and I think it's useful just to sort of set the table so the audience knows that there's ANI, which is like for maybe like a chatbot or getting me directions or something. It's very good, but only in one very specific domain. So that's ANI. And then AGI is general intelligence. That would be kind of equal to a human. Then you could talk, like I could talk about movies or politics or AI or healthcare. We have ANI already, I would argue. It's already in place and working. We don't have AGI. And then this next thing that I'm just now beginning to see, ASI, which would be smarter than super intelligence. So it's AGI is the same as humans. ASI would be, better or faster or more able to learn. What is your view of, is AGI coming soon? Is it ever going to come? And then how do we as humans navigate this? And we don't need to get into all the sci-fi movies, but if we don't have control over artificial intelligence, can we be confident that it's going to be used for good?
So, well,
Maybe
you're right. AI is being used right now. Whether it is reading radiographic images or looking at prevalence of certain disease and stuff like that.
Yeah.
But where I feel most people try to get stuck is comparing humans with the machine. That's where they get stuck.
Okay.
For example.
There. So explain.
Yeah, I'll give you an example. Yeah. Let's say I want to dig some dirt. I am digging dirt, and I can use a shovel. I can use any number of tools. What if I use a bulldozer? You can't compare yourself with a bulldozer. Obviously, it can move a lot of dirt. And now the question is, there's always a driver. Somebody has actually designed a bulldozer. Somebody is actually controlling a bulldozer. Somebody is actually moving it in different directions. And that's how I look at AI in the current situation. Yeah, maybe in 100 years from now, maybe, you can have autonomous robots doing doctors' work. But the problem with that is that, we are always worried about our own jobs or our own relevance, our own existence. For example, if you're a hole digger, or if you're moving dirt manually, you think about, oh, this bulldozer can do much better than me. But that does not mean that the human does not have a role in the actual machine working. So somebody has to design the algorithm. Somebody has to actually make it functional. Now, can the bulldozer go by itself and do some damage? Of course it can. But as long as we have controls, and so the controls are the things that make the difference. So we need humans to be able to do that. Number two, can we see bad outcomes from these machines? Of course we can see bad outcomes. Self-driving cars can still have accidents, right? That does not mean that we should not go into that route.
Yeah,
maybe the overall accidents would be less than.
Yeah, every car has some percentage of accident likelihood, and there's the question of which is safer, and for the whole society, which is better.
Exactly. So we are always seeing that the rare end accidents are getting less and less as technology becomes better and better. And so we have to think about how does it help the society, or how does it help the humanity perform. And so number one, we cannot compare it to the human because there's no comparison. Machines can do different things better than humans. Humans can do different things better than machines. Number two, can bad things happen? Yes. And some of that may be how humans have designed it, right? Some of the, our own biases getting into the algorithms that can change how the algorithms work.
Yeah, or maybe not all humans have society's best interest at heart. They may be looking for profits or something else that is, they designed it that way.
Yeah.
Yeah.
Exactly. And so you cannot blame the algorithm or the AI, but it's the person who is designing it and deploying it that is responsible for the actions of that. Eventually, AGI, yeah, sure, it can happen. But again, I would say it's a long way from now. There are so many other
50,
problems.
100 years before we get there. We're
Yeah.
going to have these domain-specific ANIs, like you said. I mean, that's a perfect example. Reading a radiology image, that is screening for cancer in 1,000 radiology images. A machine can do much better. And then maybe a human is overreading it, right? Like these 20 look suspicious. Now let's let a real expert look into that detail.
Yeah, I mean, there will always be a human's role in those kinds of situations because obviously, human body and human disease, can there's a wide range of disease, right? Even we looked at diabetics, type 2 diabetes. Uh, when we try to look at the variables, patients fall into different clusters. That means there are different types of type 2 diabetes.
Mhm.
And so these different types will need different
People
kind of
respond
treatment.
to different incentive structures.
Yeah. And so there's a lot that machines can do before we feel that, oh, they're dangerous.
Mhm.
So there are a lot of basic things that we can achieve from using those technologies.
So you're in the middle of this. Talk about some of the AI use cases that are exciting right now. That where you're seeing they're beginning to come into the market. Maybe that you have through your company, InnovatorMD, or that you've seen in the marketplace. Where do you see AI really making a difference today?
Sure. So, one of the big areas and my favorite areas is where, predicting outcomes.
Mhm.
For example, if drug A can be used for a disease, what are the other things that drug A can be used for? Is it just that one disease that it was approved for?
Mhm.
If you look at 1 million patients who are taking this drug, what are the other benefits that you can see in these patients? So there may be other use cases for these drugs, right? Or the opposite of it could be true too, where this drug is causing a problem in the long run in a patient that we may not be able to recognize in a routine practice. So those are really fascinating for me. Trying to find the drugs that work best for a certain condition in a certain type of patient. We have.
You really need a huge amount of data to get that population view of what's happening.
Exactly.
That one individual doc almost could never see. They don't have the perspective or
They can never see that.
Right, right.
And a lot of these problems that we're seeing, for example, we talk about kidney failure, dialysis. It's such an expensive, painful thing for patients to go through. And it's so expensive also for the payers. Well, what if we could find 80% of the possible causes for patients going into kidney failure and preventing them from happening? And I am sure if we have enough data that we can find things that we can change. So number one, we need huge quantities of data with number of patients. Number two, we need a longitudinal data so that we can see how these trends are changing. So it's like, rewinding the tape and going back and looking at, oh, how did this patient end up here? And how can we go back and change that? That's where I feel that.
And is the data in the EMRs now sufficient for that or not? I don't know that it is. You think it is?
I think there is enough data. Yeah. I would say, some of the organizations have been collecting it since 2000, early 2000s.
Mhm.
And so there is enough longitudinal data to actually make these predictions work. Whether it is detailed enough? Maybe, maybe not. But at least you can see the trends. At least you can see, oh, maybe there is a correlation here between this drug and this bad outcome that is happening. And so that is fascinating to me.
Yeah.
And wherever, we have to use, for example, the other area that I think is fascinating is, by the way, neck pain and back pain is the #1 cost area in the USA right now. It's not heart attacks, it's not diabetes, it's not cancers. Neck pain and back pain. Now, I mean, it's very unique to the US. So if you can take that, okay, how are we spending $100 billion or something like that on these two diagnoses? Is there something we can actually do? Are there exercises that you can recommend to a patient? What actually works? What actually doesn't? How do we find those few rare things where it's a disaster if you miss it? Those are the kinds of things that really, really help to predict, what are the actions you need to take? What are the medications? What are the operations that work or don't work? Maybe a lot of them don't work.
Now, and then it will prevent a bad event a year from now at a 70% likelihood. So I wouldn't always hit that bad event, but 70% of the time I would. And if
or 10 years from now,
I do this PT exercise, that risk down dramatically to 5% or something.
Yeah, or yeah, in the case of kidney failure, maybe certain drugs are causing the kidney toxicity.
Yeah,
that they're not recognizing, or maybe the hypertension.
You have these two drugs together. There's no external signs, but it's really hard on the kidneys.
Yeah, or maybe a hypertension drug that really changes the bad outcome into a better outcome. Mm-hmm. So far, we never had big incentives to be able to track outcomes, and that's where I think this technology is going to make huge progress.
Yeah.
In the cost and also the quality of care.
Yeah. Okay, great. And so the last thing I wanted to talk through is you've been working on this, really pushing on improving health as a physician, and then at the systems level at Kaiser, and now even broader than that. What have you learned? What do you wish you knew in 1992 when you started that you know now?
I mean, like investing in companies.
Yeah, I mean, I guess investing.
Just kidding.
You go back and talk to Uli 28 years ago, what would you tell him?
I would say whatever you're learning now is going to be obsolete in a few years. Yeah. So I would not spend so much effort, trying to understand things or learn things, especially in medicine, because a lot of things that we knew as the gold standards, they are changing.
Yeah,
everything is shifting. For example, diagnosis. Let's say a diagnosis. Well, a diagnosis is only as good as our understanding of the disease. And as the understanding of the disease changes, the diagnosis changes. Yeah. And it's not a fixed thing. And so everything is in this fluid state of motion that we need to keep track of to understand systems better. So that was one thing.
Yeah, I think that's really one of the things I'm trying to teach my kids now, really. I have 2 teenage boys, is that the pace of change in the world, technology and geopolitics and healthcare and everything is just accelerating, right? So it used to be my grandfather had 1 job, and then my dad had 5 jobs. I'll probably have 10 different careers. And my sons will have sort of every 3 years, they'll be doing something different and they'll be hopefully lifelong learners. You have to be lifelong because the stuff you're learning is always shifting. You can't stay stagnant.
Exactly. I have 2 boys in college, and I was really thinking hard whether I should push them into college or not. Even the advice, do you really need to be in college? I mean, it was a tough decision.
Yeah. I mean, the answer is no, unless it is colleges teaching them how to learn. I mean, that there's some value in that, like learning how to learn and gather information compared to your
getting
the world.
Getting the discipline of learning also, right? It is challenging because kids in the future or future adults are going to be in a totally different job market, and we don't even know what jobs are going to come in the future, right? And so how do you prepare for something that you don't know what it is, other than honing your skills and getting the soft side of skills better. How do you work with people? How do you show empathy? How do you do leadership? That becomes even more important. How do you promote yourself? How do you influence others to your vision? And those become more important.
And then that learning how to learn, like how do you read and ingest and gather information, apply some kind of critical lens to it, and then compare with your peers and with other folks so you can quickly kind of keep up with the pace of change. That's a real skill that I think schools, high schools, and colleges need to teach more than just the facts.
Yeah. So if you want me to, say critical thinking, creativity, some form of data science is what you need to be able to solve problems of the future.
Yeah. Okay. Well, that's excellent. So for InnovatorMD, when's the next event? I know you do events and programs. What's the next one coming up?
The next one is coming up in, well, actually October. There is a course for physicians on.
Is there a website or something that we should tempt?
Yeah, InnovatorMD.com.
Okay.
And so we do courses. Well, this one is about how do physicians invest, so about investments. And then we have a monthly meetup, which is every 3rd Thursday of the month. Next one is in November. And there we're talking about clinical trials and how can physicians get involved. And in January, we are doing the big conference, which is the Global Summit, InnovatorMD Global Summit 2021, January 8th through 10th.
Is that right?
Say that again? Yeah, San Francisco. Right. I mean, we have the space booked, but it could be totally virtual also.
Yeah, right. It's hard to know what will happen.
Right. Yeah, or a hybrid, depending on how COVID goes.
Yeah.
But yeah.
Okay.
And it's open not just for physicians, for investors, business people, engineers, anybody can join.
Okay.
On these events. They're a lot of fun.
Great. Excellent. Well, Uli, thanks for doing this. I really enjoyed it. We'll send people to InnovatorMD, and they should go to Amazon and buy the book and sort of learn.
Thank you.
To sort of work within these new times. It's going to be a fun next 10, 20 years, but also a wild next few years.
It's a great time to be alive. Thank you very much for having me.
Yeah. Okay. Thanks, Uli. I appreciate it. Bye.
All right. Take care.